Our topic of discussion here is going to be hyposplenism and asplenia. Now, these are really two different things, but they are really on the same spectrum. So as you might imagine, hyposplenia is where you're lacking splenic tissue. You can develop symptoms from that, or you might not. Asplenia, on the other hand, is a complete lack of splenic function. Most of the time when this happens, it's in one of two settings. Either it's autosplenectomy from sickle cell disease, or it's a patient who's had their spleen taken out. So we're going to talk about hyposplenism and asplenia and what that manifests. We'll also talk about splenic trauma, since that's such a common cause of asplenia, because in many cases that necessitates at least partial splenectomy. So this can be the genesis of either hyposplenism or asplenia. Okay, so here's a vignette. We're not really looking at diagnosis here. I just want you to get the idea of what often is behind asplenia or hyposplenia. So this is a common precipitator of this. We have a 4-year-old boy presenting to the ED following a motor vehicle accident. He is vitally stable. There are 2 lacerations on the lower extremities, as well as mild bruising of the abdomen. Fast exam is performed and reveals fluid surrounding the spleen along with damage to the splenic capsule. So, you have a child or anybody who is in some kind of trauma. This FAST exam, or focused abdominal sonography for trauma, FAST, is a great exam to do to look for any kind of abdominal bleeding, internal bleeding. And the reason we do this is because this is relatively sensitive for abdominal bleeding, and if that exists, we want to know about it as soon as possible. And in many cases, you're going to be getting a CT anyway, but this FAST exam is nice because you can perform it at bedside. You can perform it while the patient's in the trauma bay or in the ED, and if there's anything there, you can pick up on it right away. So we do this test on him, this sonography, and we find that there is fluid surrounding the spleen. Now you're going to be looking in the left upper quadrant, the spleen, left kidney. You're going to be looking at the liver, as well as the right kidney. You'll be looking at the bladder. So you'll be looking at various structures. But here in the left upper quadrant, we see some fluid surrounding the spleen, most likely blood, along with damage to the splenic capsule. So we get labs that are unremarkable. CT reveals a 3-centimeter splenic laceration and a subcapsular hematoma involving 60% of the surface area. He's admitted for observation. Over the next 3 days, his hemoglobin level drops and fluid continues to collect between the spleen and the kidney. When you have a patient with internal bleeding after trauma, you're certainly going to admit them. Of course, you want to get labs. We don't always expect anything to come back with the labs, and here we don't see anything. However, because he has splenic trauma, he needs to be admitted, because what happens when you have bleeding internally, it can get worse. Maybe it gets better, but it can get worse. And indeed, that's what we see here. It's not necessarily getting worse, but he's continuing to bleed. And so because he's continuing to bleed, we know that we need to refer him off to surgery. Now, if you have a patient with a splenic laceration, you're going to have a surgical consult right away. And in many cases, the surgeon will decide either we're going to observe the patient, as we did in this case, or not. And a lot of that has to do with the fact that we don't want to splenectomize patients if we don't have to. And in a lot of cases, you can have splenic damage and you don't need to do a splenectomy. It will heal, so you can observe them. In other cases, the surgeon will decide you need to do a splenectomy right away, and most of that has to do with whether or not the patient is stable. So this patient was stable, and so the surgeon, in this case, apparently had decided not to do a splenectomy right away. We'll observe him. But we notice that his hemoglobin level is continuing to drop. He's continuing to collect fluid around the spleen, and so at this point, pediatric surgery is consulted, or they should have been consulted and following this kid anyway, which they probably were. I just put this together. And he's recommended for a splenectomy, which is performed laparoscopically without complications. Some splenic tissue was salvaged. He remains hospitalized for observation and is discharged on post-op day 10. So anytime you're doing a splenectomy, it's preferable to leave some splenic tissue there, especially when you're dealing with the very young, because they rely on on that splenic function. We all rely on splenic function in the early stages of developing antibodies, particularly IgM. So we like to leave spleen tissue there as much as possible, and the surgeon will try to salvage as much as they can. So some definitions. Asplenia is the lack of a spleen that can be congenital or it can be due to surgical removal. Functional asplenia is asplenia, but it's a lack of splenic function. So in this case, you may have an anatomic spleen there, but it dies off. So a lot of times this is due to autoinfarction. We see that in sickle cell disease, among other things, but particularly in sickle cell disease, where it's exactly what it sounds like. You get infarction, the spleen, being tissue, needs oxygen, it dies off, and just kind of shrivels up and becomes non-functional. And so it's as if they did not have a spleen. Now there's other ways that you can have a spleen but have it where it's not functioning. So for instance, if you had radiation or if you had cancer where the cancer cells infiltrated into the spleen, many different ways that you can get functional asplenia. A lot of these things also cause hypersplenism, and then subsequently the spleen tissue just dies off and becomes atrophic. So that's functional asplenia. All that means is you have a spleen, but it's as if you didn't. It's functional asplenia. The spleen does not function. And then there's functional hyposplenia, and that's a partial loss of splenic function. And usually the spleen will go through this stage before it becomes just frankly asplenic. Congenital asplenia. So all this means is you're born without a spleen. This is associated with complex congenital heart defects. Complex basically meaning congenital heart defects that don't fit those typical congenital heart defects like Ebstein's anomaly and tetralogy. There's other congenital heart defects. We call them complex when they're more anatomically unusual. Dextrocardia, bilateral trilobe lungs, and heterotopic abdominal organs. This all fits within a syndrome known as Ivermark syndrome, which you've probably never heard of, but it's on the spectrum of the diseases known as heterotaxies. So what this is you know how you can have situs inversus, which is abnormal. All your organs are on the opposite side, and generally that's okay because you still have all your organs. Now there are some things, usually in a lot of cases it's due to primary ciliary dyskinesia, which that can lead to all sorts of problems, but just the fact that you have all your organs doesn't lead to any functional problems of those organs itself. Now, on the other hand, if you have something, and it's possible to have something in between situs solitus, which is everything's on the correct side, and situs inversus, which everything is reversed, and that is called a heterotaxy. And there are two different ways that you can have this. You can have basically two right sides, in which case you're going to have congenital asplenia. So if you have two right sides, remember your spleen is on your left side. If you have two right sides, you have no spleen because your spleen is on the left side. And if you were to have two right sides, so think of it as like a chimerism. You have two right sides. Now you're going to have most of your organs. You won't have a spleen. You're going to have most of your organs, but there's going to be some abnormalities. So look at this. Bilateral trilobed lungs. Which of your lungs has three lobes? The right one. And so if you had bilateral trilobed lungs, that would be consistent with a right-sided chimerism, where it's on your right side, you've got, it's like a mirror image. And so you have three lobes on your lung on both sides. So it's like you have two right lungs. Now they're going to look like a right and a left lung, but you just have trilobed lungs on both sides. Where this becomes problematic is with your heart. So remember, your heart is not a symmetric organ. And if it were symmetric, you'd have a lot of problems. And that's where you get this complex congenital heart disorder. So you can see that these are all due to the fact that you have organs forming in manners in which they shouldn't. And this is where we get this Ivermark syndrome from. Now, you can also It can also occur where you have two left sides, and in that case, you can have two spleens. You'd have a spleen on your left side and a spleen on your right side, and presumably you would have bilateral bilobed lungs. And you'd also get a congenital heart defect from that because you'd have like two left sides. Your heart would be symmetrical, and you have two left sides of your heart. That would lead to a polysplenia, and that's also another heterotaxia. These are uncommon, but they do happen. All right, so that's how you can get congenital asplenia, or one of the ways you can get congenital asplenia. Some results of hyposplenia and asplenia. So as you can imagine, if you don't have a spleen, because it has a role in early antibody formation, you're going to be susceptible to infection with encapsulated organisms. Remember that the formation of antibody and the opsonization of antibody with on these encapsulated organisms is our primary way of getting rid of them. Now, also remember that the spleen is responsible for making various factors that relate to our complement system. So if you don't have those factors, you're going to have problems with getting rid of these encapsulated organisms, since they function in your complement system. There's also an increased risk for vascular events. There's a couple reasons behind that. First of all, the spleen holds platelets. About 1/3 of your circulating platelet volume is held within your spleen. So if you are lacking the spleen, you're going to have more platelets circulating around. That can lead to vascular events. But primarily, the reason that we get vascular events from hyposplenia or asplenia in patients who lack a spleen are at increased risk for these vascular events. Primarily, we're talking about thrombus, either in the arteries or in the veins. The reason is because they're not getting rid of their damaged red blood cells. And when you have damaged red blood cells circulating around, they are more likely to initiate a coagulation cascade. And that can result in thrombus formation, which then that in and of itself is not so much a problem as a problem when you get an embolus from the thrombus, thromboembolism. And then finally, the presence of cytoplasmic inclusion bodies on red blood cells, that in and of itself is not a problem. That's just a sign of decreased splenic function. So these are some of the causes of functional hyposplenism. So sickle cell disease, that's a major cause. We see that in most patients with sickle cell disease that they're going to wind up hyposplenic. About half of patients with sickle cell disease will be hyposplenic by age 6 months, and most of them will be functionally asplenic at some point early on in childhood. Acute leukemias, non-Hodgkin's lymphoma, these can happen early on in life, and it's just because you have infiltration here of the spleen. Various hepatic disorders, certainly we don't see alcoholic liver disease in children, but these other things you can see in children for one reason or another. And remember that if you have disorder either of your hepatic parenchyma or of the circulation that's around there, that's going to wind up in increased pressure, blood pressure of the spleen, and that can lead to hypersplenism, and then it can also be destructive of the spleen itself, which ultimately is going to affect function. Autoimmune disorders can result in issues with the spleen. Reason here primarily is because of immune complex formation. Circulatory disorders, this kind of goes along the same lines as some of these hepatic disorders where you have arterial problems or venous problems, which can either choke off the spleen of blood, or it can just lead to an increased pressure in the vasculature of the spleen. It's also associated with various GI diseases. Celiac disease is notable, and then some of these GI diseases are also autoimmune disorders. And then there's other causes, so amyloidosis and sarcoidosis, both are going to cause infiltration of the spleen. And then there's some of these other ones, so we talked about irradiation. I'm not so sure about the mechanism of some of these other ones, but they're there. The clinical manifestations of infection related to hyposplenism. What do they get? When they have an infection, they tend to have really nasty infections with a very fulminant course. So they'll tend to have a massive bacteremia caused by encapsulated microorganisms. associate the spleen, associate the complement system, associate early antibody formation with the ability to clear out encapsulated organisms. So strep pneumonia, Neisseria, Haemophilus influenza. Those are your major encapsulated organisms that you're going to have difficulty with if you have problems with your spleen or problems with the complement system. They'll also tend to have no obvious primary source of infection, although in a lot of patients they're not going to be able to note where they may have gotten the infection. When they get these infections, it tends to be rapid in onset and rapid in progression. So they'll have a short, nonspecific prodromal phase, but you won't always be able to elicit that on history. Excuse me. They'll also be at significant risk for septic shock, which can be associated with DIC. Their mortality rates will be quite high. So if they do reach this stage where they're septic and with DIC, their mortality rates can approach 70%, often with death ensuing in a very short period of time. They'll also be at risk for concomitant bilateral adrenal hemorrhage. The reason there is because Neisseria is one of the common causes. Not the most common cause, that goes to strep pneumo, but Neisseria is a very common cause of infection in asplenic or hyposplenic patients, and this bilateral adrenal hemorrhage is an apoplexy syndrome known as Waterhouse-Friderichsen syndrome, and it can be quite deadly. The risk of infection related to hyposplenism and asplenia varies based on several factors. So first of all, of course, the degree of hyposplenia, so whether or not they have 30% of their splenic function or 10% of their splenic function, or if they're completely asplenic, that's going to alter their risk of infection. So obviously the more spleen you have, the better. Even if you're hyposplenic, if you have some splenic function, that's going to be better than having none. The underlying condition causing hyposplenia. So, as a matter of fact, the cause of why your spleen is not functioning, or even why the spleen was removed, actually confers a different risk of sepsis. So, for instance, if your spleen were removed because of trauma or because of red blood cell membrane defects, so if, for instance, you necessitated multiple, if you necessitated multiple transfusions due to something like sickle cell disease or congenital leptocytosis, your risk of having sepsis is only about 2 to 4%. Now contrast that with a patient who had to have their spleen removed due to a problem with something like Hodgkin's disease, Wiskott-Aldrich syndrome, or, for instance, they had one of those storage diseases like Gaucher's or Niemann-Pick syndrome, or if they had some kind of severe hemolytic anemia that necessitated splenic removal, their risk of developing sepsis goes up to about 8 to 30%. So the underlying condition that necessitated splenic removal or resulted in autosplenectomy is going to play a role as well. And then this one's most important, I would say, along with degree of hyposplenia, and that is the age at the time of splenectomy or loss of splenic function. Patients who are under the age of 5, when their spleen was removed or their spleen autoinfarcted and they went into functional asplenia or functional hyposplenia, they tend to do more poorly than patients who are older than 5 and lose their spleen. And this holds true even beyond age 5. So it doesn't necessarily mean simply because they're young and don't have a spleen, and then when they get older they'll be better off. It is true that younger people who don't have a spleen are at higher risk than older people who don't have a spleen. However, they will continue to be at higher risk even when they pass age 5. This is also why we prefer, if we're going to take somebody's spleen out, we want to delay it as much as possible. We prefer to wait until a patient is 5 years of age or older before we take their spleen out. However, in many cases, that just is not feasible, and particular case would be in a patient where there's trauma. How do we diagnose functional hyposplenism or functional asplenia. First of all, if you get a CBC and smear, you're going to note a couple things. So Howell-Jolly bodies. That's just a nucleus in the red blood cell that is normally there. However, the spleen is responsible for taking it out. And so if you have a lack of splenic function or you have no spleen, those little nuclei are going to remain there, and those are called Howell-Jolly bodies. You'll also note other things. You can note Heinz bodies, which these are just precipitated hemoglobin, and it's visible due to disulfide bonding between the hemoglobin molecules. You typically will note this on methylene blue tests. We'll look at that in a little bit. You can also note pitted erythrocytes, just little indentations in the erythrocytes. And then on sonography, you can note splenic atrophy. And you can also get a nuclear medicine test known as technetium-99 sulfur colloid scan. This not only is useful for visualizing whether or not a spleen is there or if there's splenic tissue elsewhere, but it's also useful to determine the degree of splenic function. So this will show you how much the spleen is functioning as well, in addition to where the spleen is, if it's atrophied, or if there's splenic tissue elsewhere. You may also see another nuclear test that's known as the radioactive colloidal gold test, used with 198 gold. That can be done too, basically does the same thing as the technetium test. So this is an example of Howell-Jolly bodies, these little basophilic inclusions. These represent red blood cell nuclei that should be removed, and they are removed by the spleen. But in this case, you see them, and that is a sign of either hyposplenism or asplenia. So you'll also see some red blood cell pits here. If more than 4% of the red blood cells have these little pits, so you see some right here, then that is consistent with hyposplenism or asplenia. Not a whole lot of them here. You can see some here. For the most part, these red blood cells should have a smooth, they're not perfectly circular, but they should have a smooth texture, a smooth membrane. But you see here that there's some pits in some of these cells. So again here you see some pits here, pit here, and then these basophilic Howell-Jolly bodies. These are Heinz bodies here. This is done with a methylene blue test. So you wouldn't see this on your typical H&E or just looking at red blood cells underneath the microscope. You have to do a specific test for this. And they look just like Heinz bodies. The only difference is you'll only be able to visualize this on that new methylene blue test. Okay, splenic trauma. I talk about this in the trauma surgery section, but it's worth going over again. This may occur with abdominal trauma because the spleen has such a rich vascularity. It is a prime place for fatal bleeding. So if you have a rupture of the spleen, there are some things that you're going to pick out. First of all, abdominal pain. Anytime you get enough trauma to the abdomen to cause splenic rupture, it's going to be enough that's also going to cause abdominal pain. So the spleen, if it's not enlarged, if it's not diseased, it doesn't rupture very easily. It's a relatively hardy, stable organ. You have to have significant abdominal trauma in order to get splenic rupture. Now, the exception here is, let's say you have mono and your spleen is already enlarged, then it's a little bit more frail. And that leads to this other point here, that spleens which are enlarged for other reasons or have been previously enlarged, they are at higher risk for rupture. So let's say you had mono 5 years ago. Even if your spleen's not enlarged now, if your spleen has been enlarged in the past, you are at higher risk for rupture. Not as high of risk as if your spleen were enlarged. Let's say you're mono right now. Your risk is certainly much higher right now than it would be 5 years from now. However, if your spleen has ever been enlarged, you're at higher risk than if your spleen had never been enlarged. So the symptoms are abdominal pain. This can refer to the left shoulder. Why to the left shoulder? if you have, and we're going to see a picture of this, if you have fluid or blood collecting around your spleen, remember what the spleen is right up next to. It's next to the rib cage, it's next to the left kidney, and it's next to the diaphragm. It sits right up on the bottom left-hand side of the diaphragm. And if you have a collection of fluid there, it's going to irritate the diaphragm. It's your phrenic nerve there. If the diaphragm is irritated, it's going to refer pain to the left shoulder. And you'll also note this if you do so surgical patients and you do laparoscopy on them. And of course, when you do laparoscopy, you have to insufflate the abdomen. And when you deflate the abdomen, most of the air is coming out, but there's still going to be some free air in the abdomen, and that air is going to push up against the spleen, and that causes pain in the left shoulder. That's very common. So you see post-operative patients, they had splenectomy for they had laparoscopy for one reason or another, had their appendix taken out, had their gallbladder taken out, maybe had gynecologic surgery. And you see them the next day and they're saying, oh, doc, my left shoulder hurts, or my shoulder hurts, my back hurts. And it's usually like suprascapular pain or periscapular pain. And that is tremendously common. It's perfectly normal after laparoscopy. However, with splenic trauma, if you see, or abdominal trauma for that instance, if you were to have a patient with abdominal trauma and pain in the left shoulder, that should point you towards possibly something going on with the spleen where there's maybe some fluid around it. Of course, you're going to pick up on this pretty quick if you're doing your FAST exam, which you should in any patient with trauma. More severe tears can cause significant bleeding, and that can lead to hypovolemic shock. Yes, you do have, you need two things to have hypovolemic shock. First of all, you need to have a source of significant bleeding. So you're not going to go into hypovolemic shock with a laceration of your arm. However, on the other hand, if your spleen were to lacerate, there's lots and lots and lots of blood right there. You also need something else. So even though there's rich vasculature, you need to have place for that blood to go. So a good example here would be if you were to hit your head. Yes, you have rich vasculature in your brain. However, there's not a lot of space for the blood to go up there. You're going to go into uncal herniation before you have hypovolemic shock. So you don't have really any space there. On the other hand, your spleen sits inside your abdominal cavity. Plenty of room for blood to go. So you've got these two things. You've got rich vasculature, ways to bleed out, and you also have places for the blood to go. And the two of those together can cause hypovolemic shock if you have trauma. And so the spleen can, if it's ruptured or if it's damaged, it can bleed enough to cause hypovolemic shock. So if you have a severe enough tear, you're going to have the abdominal pain, you're going to have reference to the left shoulder if the patient's awake and can tell you this. And then, yes, you can go into hypovolemic shock. And this is the reason why we remove the spleen if it's damaged enough, because there's going to be bleeding, and we don't want the patient to lose too much blood. So for diagnosis, you'll start out with sonography. This is not the most accurate test for diagnosing splenic trauma, but when a patient is coming in to the trauma bay or coming into the ED, and there's lots of things you need to work the patient up for. Sonography is easy to do, very quick, and this is the best test to start out with, because if you don't see fluid around the spleen, there's probably not splenic trauma. Now, the problem with sonography is that it is dependent on the skill of the operator. So if you don't know how to do sonography, it's going to be very difficult to pick up on if there's splenic trauma there, certainly. You don't have a radiologist there to help you. And if you get a CT, presumably that's going to go off to a radiologist. That's going to help you. So we start out with sonography. Provided the patient is stable, if there are findings suspicious for splenic trauma, then you can go ahead and do a CT. You'll want to do that with contrast. Now, most of the time, when you have a patient with significant trauma, you're going to be getting a CT anyway. But if you suspect splenic trauma, make sure that you're getting a CT with contrast. It's going to be a lot easier to see that bleeding on CT. So this is an example here. This may have been what we had seen in this child in the vignette. So here's our spleen here, the left kidney. Note that the spleen is very homogeneous in texture. Compare that to the left kidney, which is a little bit more echoic, with the exception of the renal pelvis. Here, there's a little bit of space in between the spleen and the, well, if you look right here, there's some, what might be a collection of fluid here. This is your splenorenal ligament, which looks perfectly normal. You should have this sort of echodense region here. However, what we see abnormally is this collection of fluid here along the lateral aspect of the spleen. And so your spleen you should have very little space around the aspect, both the lateral and medial aspect of the spleen. But you do see some fluid collecting here and a little bit collecting here. So here you see fluid collecting on the opposite side. So here you see the spleen here, kidney here, and then fluid collection here. This is your splenorenal ligament. This is a good place to look to see if there's any fluid. Now, of course, that fluid is going to be, where it is going to partially depend on how the patient is laying. It's going to collect in gravity-dependent areas, but this is your fluid here. So the best way to do this is just look at the spleen, and you should not see too much fluid collecting around the spleen. I don't know how to put that any simpler, but your bodily structures should be nice and snug next to the spleen here. So visualize your kidney, visualize your spleen, and then look to see if there's any fluid around it. Okay, this is a CT. So you can see here that the CT is quite more useful in visualizing problems. See the splenic capsule here, possibly some fluid developing here, and then you also see a laceration. So there's a laceration, and there's also this localized bleeding. Here you see a subcapsular hematoma. So this is your capsule of the spleen here running around. You see, I think this is probably the splenic artery here. And then you see this, this region here where there's bleeding. Obviously a different resonance than the rest of the spleen. This looks like possibly, or I'm not a radiologist, but this looks like a laceration of the spleen here. But this is blood collecting in between the capsule of the spleen and then the parenchymal tissue. Our management. So we saw this in our vignette. What do we do for splenic trauma? We prefer not to do surgery. Why? Because if you take splenic tissue out, the patient is going to be immunocompromised after that. So for small injuries, if they're clinically stable and the injury is limited to the capsule, then they should be admitted for observation, and you're going to be paying careful attention to their vital signs, blood pressure, pulse, and then also their abdominal symptoms. So if there's abdominal pain, that should gradually subside. Serial hemoglobin, just to keep an objective view on whether or not there's blood loss. Of course, you want to make sure surgery is on call. So if they're at a hospital where there's no pediatric surgeon that's constantly on call, then they're going to need to be transferred somewhere else. Activity restriction after discharge, usually it's going to be several months of activity restriction as that spleen heals itself. For larger injuries, these are patients who are unstable or they have a deeper injury, and that really is, the radiologist will grade the splenic trauma. It's like grade 1 through I think 5, where 5 is the most severe, and that's like your shattered spleen. And then if there's deterioration, if the patient's been admitted for observation, or if other organ damage is suspected, which is going to necessitate laparotomy or laparoscopy, then in that case, you're going to be doing surgery. So obviously the last criteria here, if there's other organ damage suspected, the reason for that is obvious. You're going to be looking at other organs anyway, so you may as well look at the spleen, but then these first three, if they're unstable, if it's a deeper injury, or if there's deterioration, obviously surgery is important because you want to see if the spleen can be salvaged. This can be done either through open surgery or through laparoscopy, and the surgeon is going to take out as much spleen as they need to and no more. The surgeon is going to try to keep as much splenic tissue there as possible. The more splenic tissue that remains, the better off the patient is going to be immunologically. Partial splenectomy is preferred if feasible. You don't need to know in what cases you take out spleen, in which cases you don't. That's a very complex call on the part of the surgeon. But just know partial splenectomy is preferred if feasible. And know that patients who are unstable or have more significant, more severe injuries, or patients who have been admitted for observation who deteriorate or who do not improve, they're going to need surgery. So our indications for splenectomy include trauma, as we've talked about. Some anatomic defects will necessitate surgery, so that really depends too. So things like cysts and pseudocysts, if they get big enough, that may precipitate the need for surgery. If there's severe transfusion-dependent hemolytic anemia, if they're requiring transfusions every couple of weeks, obviously you want to remove the spleen. Why would that help? Because remember, the spleen is responsible for various things such as complementation. If you have things like spherocytosis or elliptocytosis, the spleen is going to clear those blood cells out, or pull those blood cells out. That can lead to an anemia. And if you take the spleen out, then those blood cells will remain in the circulation. Remember that things like elliptocytosis and spherocytosis, those blood cells are capable of delivering oxygen, but the problem is they're removed from the spleen, or they're removed from the circulation. And so if you take the spleen out, then those blood cells will stick around and you'll abate some of the symptoms of those disorders. Immune cytopenias, metabolic storage disorders, secondary hypersplenism. So these are some of the reasons why we would do splenectomy. The major long-term risk is infection with encapsulated organisms. What are our recommendations here? This I got from the literature. If possible, delay splenectomy. Like I said, wait until at least age 5 to remove the spleen. That would be ideal. It's been shown that there's better survival the longer you wait. If you're going to be removing the spleen, then you should provide pneumococcal, meningococcal, and Haemophilus type B vaccinations prior to splenectomy. I'm not exactly sure why it's necessary to do it prior to splenectomy. I think what I read was at least 2 weeks prior to the splenectomy. But my inclination is that because the spleen is responsible for the initial production of antibody, if you do this before you remove the spleen, you're going to have more antibody circulating about when you remove the spleen. And the first several months after you remove the spleen is when the risk for infection is greatest. Of course, leave as much splenic tissue as feasible, and then after the splenectomy is performed, the patient is going to be placed on antibiotic prophylaxis. So how long do they need to be on antibiotic prophylaxis? The recommendations are at least 2 years or until age 6, whichever is longer. So let's say they had their spleen taken out at age 8, they're going to be on antibiotic prophylaxis until they're 10. If they had their spleen taken out when they were 2, they're going to be on antibiotic prophylaxis until they're 6. So whichever is longer. And we do antibiotic prophylaxis with penicillin V, which can be taken orally, 125 milligrams if they're younger than age 5, twice a day, 250 if they're older than 5, again, twice a day. If they are allergic to penicillin, you could probably substitute it with something like erythromycin, which basically does the same thing. Now, the controversy is whether or not lifelong prophylaxis with antibiotics should be considered. And what I gathered from the literature is yes, it should be considered if the patient has a history of significant infection with encapsulated organisms or if they are immunocompromised. So for instance, a patient that may be immunocompromised that we may consider splenectomy on would be a patient with something such as Wiskott-Aldrich syndrome, where they're going to lack T-cell immunity too. That would be a patient in which you would want to consider antibiotic prophylaxis. Okay, here's a vignette. to just kind of close us out. So an 18-year-old woman presents to the ED complaining of fatigue and body aches over the last 3 days. She has no other complaints. Her surgical history is remarkable for splenectomy at age 5 due to trauma. Her past medical history is unremarkable, and she's not presently on any medications. She's a student at a local university where she's majoring in chemistry. She denies alcohol, tobacco, or drug use. She's not on any medications. Vital signs: blood pressure 110/80, heart rate 105, respiration 14, temperature 100.8. Patient or physical is remarkable. For mild neck stiffness. Kernig and Brzezinski sign are negative. Lungs are clear to auscultation. Abdomen soft, non-tender, non-distended. Normal bowel sounds. No rashes. No papilledema or symptoms of increased intracranial pressure. She's neurologically intact. So this is a question like what you might get on step 3. So the question is, do we need to do labs? If so, what kind of labs? Any procedures need to be done? Any imaging need to be done at this point? Should she be placed on any medications right now? And what do we do with her? Are we going to admit her? Are we going to send her home? Are we going to observe her in the ED? What do we do? So you can go ahead and pause it here if you want. I'm going to move on. Okay. So let's just evaluate this patient. We have a patient who is splenectomized. It's not really important here to what degree she's been splenectomized. We just know if you have a patient who says they've had their spleen taken out, you should just assume they're missing their complete spleen. Don't wait on the surgical report. In a lot of cases, you won't be able to get it. This was done 13 years ago, so we're going to assume she's asplenic. She has no significant past medical history, so we're assuming no major infections. Good thing to ask the patient is, have you ever been in the hospital for any reason? But her past medical history is unremarkable. She's obviously not sick at the moment other than what she's coming in with. She's not on any medications. She's 18, so we know that people who are 18 think of infection in young adults, especially young adults who are in college. We're always worried about meningococcal meningitis. Her social history is pretty clean. Her vital signs, so everything looks good except for this temperature, which is consistent with some kind of infection. And the fact that she's got fatigue and body aches, we always think of infection there too. She's got a fever. So right here, this is what I want you to get out of this. You got a patient who's splenectomized and has a fever. Every patient who is splenectomized with fever, they are going to be on antibiotics without exception. So patient with no spleen plus a fever, antibiotics. The antibiotics we're going to put them on is going to be broad spectrum, but particularly we want to cover strep pneumo and Neisseria. And we do that with a 3rd or 4th generation cephalosporin and vancomycin. We add vancomycin because we're always concerned about possible resistant bugs. So this is good broad spectrum coverage. So she's immediately going to be placed on ceftriaxone and vancomycin. She can wait a little bit so we can get these blood cultures, but we want to get basic lab work on her, CBC, BMP, CMP, whichever you prefer. I guess I prefer CMP if it's the first one you're doing on a patient. You can then follow her up while she's in the hospital with BMP or electrolytes or just hemoglobin. I mean, really just depends on what you're following, I guess, if anything. But then we also want to get a urinalysis. Why do we want to do a urinalysis? Yes, it's looking more like meningitis, possibly, because she's got the mild neck stiffness. However, you want to look everywhere for infection because you know that this is an immunocompromised patient, and if she were to deteriorate, you want to make sure you have everything covered. So we get a urinalysis. We also get blood cultures and urine cultures, and then we're also going to get CSF cultures too. So you're covering all your bases. And this is similar to what you would do in a very young child with fever of unexplained origin, where you're looking for any possible source of infection. Why are we going to do a spinal tap on her? Because remember, patients who are lacking in the complement system or who are lacking a spleen, they're at risk for encapsulated organisms. What are 2 of the encapsulated organisms? They're strep pneumo and Neisseria meningitidis. What do those also happen to be? They happen to be the big culprits in meningitis. So we're going to do, and also for the fact that she's got a fever and neck stiffness, so we want to do a spinal tap. We'll get CSF, do an analysis on that, and then also culture it. Even though we're doing all these cultures, we're going to place her on antibiotics right away. I would want to put this patient on antibiotics right away, even if she hadn't had a splenectomy, because this is so consistent with meningitis, and even non-splenectomized patients can wind up with meningococcal meningitis. So we would put her on broad-spectrum antibiotics, ceftriaxone, vancomycin. Of course, we would want to admit her. So even though she is stable right now, you never know if things are going to get worse. She's got neck stiffness. She's essentially immunodeficient, so we want to make sure that we're keeping an eye on her. And so we will keep her at least overnight for observation. There should be some improvement within the next couple days, but certainly if the CSF comes back dirty, which I guess you wouldn't know right away, it'll take a couple days, but if the blood cultures come back positive, then she's going to be kept in longer. Now note here that there are no rashes, so she's not in a fulminant meningococcal sepsis. Then also there's no papilledema or signs of increase in intracranial pressure. I talked about this in the previous section where we had a patient with fulminant meningitis. Sort of the same thing here. Do we want to ever do a CT, or do we want to do a CT before we do a spinal tap? Now, you never want to do a spinal tap in a patient where you suspect elevated intracranial pressure, because it increases your risk of herniation. Remember that your CSF is sort of counterforce against herniation. If you pull CSF out, you increase your risk of herniation. Because there's no signs of increased intracranial pressure, you can go ahead and get the CSF and don't wait to get a CT, because that's just prolonging things. However, if there were signs of increased intracranial pressure, then you'd want to get a CT and possibly hold off on the CSF analysis. Remember that you don't need to get a CSF analysis to start antibiotics. We prefer to get a CSF analysis. It's just more comprehensive workup. But you don't need to defer your. Let me put that the other way. You don't need to defer antibiotics to wait on a CSF analysis. Most important thing here is get as much done as you can, but get those meds in her quickly, because that's going to help with the infection. So that's all I got for you here. If you have any questions, go ahead and write me a note below, and I will see you next time.